welcome to the BSS session. So we're going to start off with some free papers, and then we've got a nice lecture by Pat Kiley. So if I can ask the first speaker to come up on stage, which is Dave Moore, on predictors of intraoperative monitoring problems in pediatric spinal deformity. Is he here? Oh, maybe we will catch up.
Anybody laying claim to the first paper? Right, let's move swiftly on to the second one. So, Dr. Harshava. Oh, Alex coming up.
Oh, thank you.
I'm sorry, Alex Gibson from Stanmore. Harshava can't be here today. He's had to go and is the first author on this paper. So I said I'd be happy to stand in and do perhaps half as good a job as he would have done. So it's really to talk about our experience of the magic rod. Right from the very beginning when it was first implanted. So this is a 10-year follow-up study. It's just a retrospective review of our cases, basically. Here are our disclosures. So just a bit of background on the US. I'm sure you all know that the magic rod was sort of developed because it was felt that in some cases growth guidance and early spinal fusion wasn't doing a good enough job. There's a novel implant back in the day, but it has now been in use for more than a decade. Approved for use in early onset scoliosis, both in the USA and by NICE in 2013. You know, this discussion is really what are the advantages over a traditional growth rod or conventional growth rod, and can we even try to work out whether there's an advantage in the fewer number of anesthetics on which is of concern in a maturing brain. So this is, as far as we're aware, the first, if not one of the very first, of studies with more than 10-year follow-up. So the aim is to report our results using both single and dual insertion of magic rods in the UK, to report on our adverse events and complications and to work out whether it's still reliable and useful implant, and to share the lessons learnt in its use, which is primarily Hilali's use, but I've got a couple of patients in the group as well. Okay, so I'm going to take you on a time-traveling journey of 15 years in less than 5 minutes now. We looked at all our insertions undertaken by two surgeons, both de novo magic insertion, that means no previous surgery, and there was one case where a early conversion from a traditional growth rod to magic, and a minimum follow-up is 10 years. That means the last surgery, it's more than 10 years now, but when we prepared the data, the last surgery was done in 2013, January 2013. Inclusion criteria, you can see basically Cobb angle in the operative range, but a thoracic height indicating that there's still significant growth remaining and expected bone maturity that would be concordant with that, and progression despite brace wear. In other words, failed conservative management. We excluded early onset scoliosis treated in other ways, of course, and if we were successful in our non-operative management, we would carry on doing that. So 29 patients, 11 boys, 18 girls, both treated both at Great Ormond Street and at Royal National Orthopaedic Hospital in London. Most of them were de novo magic rods. 9 were single rod, and then we started to move to dual rod insertions, and the etiologies are up there, you can read them. And so this is a little bit about the insertion technique. So 2 incisions at the top and bottom foundations, and then submuscular passage of the rods between the 2 incisions. Upper anchors were usually hybrid, hook and screw. Lower was usually was almost always all screws. The technique that Hilali liked to call the Taj Mahal fixation is with transverse process hooks at the top here for a couple of reasons. One is to apply a different type of force, but also to prevent translation of the screws medially, which might encroach on the spinal canal. And the reason he called it Taj Mahal is apparently the little towers to the side of the main building slant outwards, so in the event of an earthquake they fall outwards and they don't damage the main building. So I learned something. So these are the results. So all of them are under 10 years. Follow-up duration mean is 13 years now. Cob angle at the first visit 57 degrees and progressed to 71 degrees before surgery. Immediate post-op angle, Cob 45 degrees, and final follow-up was 57 degrees. So maintained, although there's some progression of the Cob angle during the phase of surgery, during the follow-up, obviously there's a lot of growth that's been going on, and it's still maintained a Cob angle at about what it was when they first came to see us, and we've gained all that trunk height, average of about 89 millimeters over the course of the study. His case showing a couple of issues and problems with them. First generation rod, you can see fracture of the distal rod at the bottom of the housing, which was converted to final fusion, and then there's 10-year follow-up on the far right screen there. Although he's got a residual lumbar curve, hasn't required any further input. This is for an SMA case, and you can see that despite good lengthening of the rods and growth of the spine and maintenance of the Cob angle, obviously it doesn't have an effect on the ribs and on the lungs. You can see still that parasol deformity secondary to the underlying condition. The welding problem was an issue in the first rods. We can see that it's been apparently fixed now. Other problems we've had were that it didn't distract, failure of distraction, and was acting effectively as a tether, so it was converted to a fusion. And then we had a few cases where it would distract, but then it would sink back with time. And the solution to that was to wear an external magnet. Again, that issue doesn't seem to be a problem in the current generation of rods. Another technique that we sometimes had to use was if it was difficult to place, particularly the convex rod, we put it in an upside-down orientation because it would allow contouring of the longer, what would normally be proximal end, into the lumbar lordosis. So that's the summary of what's happened with the manufacturing problems, first generation, welding issues, second generation, with this keeper plate, which helped to prevent the loss of distraction, and then the monoblock construction in the third generation. So a few proximal junctional kyphoses, all addressed at the time of the definitive posterior fusion at the end of the growing phase. Three distal junctional kyphoses, again addressed at the final fusion. 2 deep infections, 1 needed explant, and some lumbar curve decompensation as well. But overall, the total number of surgeries in these 29 patients was 40. Okay, so that includes the unplanned returns to theatre and all the complicated stuff. So it still maintains, it still reduces the number of general anaesthetics and surgeries that these children have to go through. So, I mean, I invite you to draw your own conclusion, but my conclusion is it's still a very valuable implant.
Over time.
Thank you very much.
Thank you. So in the interest of time, if you've got any questions, maybe we could do that outside because we're slightly over time. So next talk is it's Darren Louis.
Yeah.
Again, sorry. A new vibe, MRI-based synthetic CT scans analysed for creation of custom-made 3D spine models, which we just heard, haven't we?
Thank you, everyone. Thank you, Chairman. I'm Darren Louis. I was working at St. George's Hospital when we produced this paper. I'd like to thank Chuck and Liam and James who put the slides together and did a lot of the work. the conflicts of interest is that I did receive a small stipend to attend a lunch symposium today by one of the companies, and I got a free day pass for the BritSpine today as well. So the other thing to say is that we have been using 3D models and jigs for scoliosis surgery at St. George's. We've got 90 cases done, and therefore we don't have navigation, and so the standard of care has been to do a preoperative CT as well as a whole spine MRI in the workup of these cases. And the CT scans are used to produce custom-made spinal jigs, which can then be used to insert pedicle screws with precision and accuracy. So what we wanted to do was take the synthetic CTs and compare it to true CTs. And as I described, we'd previously presented here at BAS and AO Spine last year of the first 55 pediatric cases, which showed good results. So how does this work? Well, what happens is an MRI is performed. You have to add a software package to your MRI scanner. It is agnostic to the MRI scanners that you have in your hospital. At the moment, it's an extra 4-minute spin, and this will then be transferred, anonymized into the cloud-based server of the company that has the software model to take that DICOM image of the MRI and convert it to a diagnostic quality synthetic CT that is then transmitted back to your hospital, and your PACS servers will re-merge the patient data with that to go into your PACS system. We had explicit consent obtained both for the traditional CT and the synthetic CT, as well as the data to be transferred to the manufacturer. The models were overlaid and compared for similarity. So I'd speak a little bit about this. Volumetric analysis is done by something called dice coefficient, and that's done by our 3D model manufacturer. We then had the surface geometry, what we call the surface distance or the mean surface distance, done by the synthetic CT provider. And in these two ways, the engineers are able to match and prove objectively whether or not these scans are useful for a diagnostic level quality. We only included patients over the age of 16 for this small trial, idiopathic scoliosis, and designated for posterior spinal fusion, and they had consent for both scans. So the DICE coefficient, you're looking for a proportion of 1.0, and ideally you want to get as close as that as possible. And the mean surface distance is where you overlay, and the difference in boundaries is expressed in millimeters. Deviations of less than 2 millimeters are considered pretty good for navigations, and sub-millimeter is considered excellent. So when we took all of the 4 patients that we had at this point, and then we mapped every single level, T1 to L3, or whatever levels we had within the scan, we then had each of the engineers perform their mathematical modeling either for the DICE coefficient or the MSD to get the results. And so the mean DSC was 0.94, so it's very close to 1, which means that from an FDA and a CE point of view, it is diagnostic quality, and from a modeling point of view, it would be sufficient to create a model. And then we looked at the mean surface distance, and we can see that we had sub-millimeter accuracy, so the overall MSD was 0.58 millimeters. In the lumbar spine, 0.65, and then the thoracic, 0.58. So again, given all the levels of the spine, each one objectively measured by 2 different methods, these are objectively similar. Here's a visual comparison of what the CT looks like compared to the synthetic CT. Of course, they look very similar. So in conclusion, spinal modeling from synthetic CT-based MRI scans are highly comparable to those based on standard CT scans. The mean DSC of 0.94 absolutely satisfies the FDA and CE criteria to produce spine models, and the mean MSD certainly satisfies the criteria to create synthetic CT as a diagnostic quality CT. And this has the advantage of now creating a safe navigation tool, whether or not it's going to be a robotic system, a topographical system, or the 3D model system. And I think hopefully we will see more of this in the future. Thank you.
Thank you, Darren. So the fourth paper has been withdrawn. So can we invite Susanna Tucker or their team on promotion of sports and exercise in AIS?
Hi, my name's Susanna Tucker. I'm a senior physio at the Royal Orthopaedic Hospital, Birmingham, and PhD student at the University of Birmingham. So today I'm presenting post-operative participation in sports and exercise and physical activity following spinal fusion. So this is the first international expert consensus. I'd like to thank my co-authors listed and the Birmingham Orthopaedic Charity for funding this work, and we have no disclosures. So the overall aim of this study is to determine expert consensus, on the following things. So firstly, timelines and milestones in returning to sport and exercise following and physical activity participation. And second, to look at MDT involvement and philosophical approaches to rehabilitation. So this was an international sample we've gone too far. So there was an international sample of 53 experts. I'm not sure why that's not appearing on the screen, sorry about that. We had 26 surgeons and 27 physios. So it was a 3-round Delphi survey. So round 1 was a series of open-ended questions. Round 2 and 3 involved a collated summary of results. During round 2 and 3, participants rated their responses on a 5-point Likert. And the definition of consensus was defined by agreement for each round. So here's a geographical representation of where all our experts came from, and a statistical summary of our results. So from the 85 statements that were generated at the end of round 2, 66 achieved over 75% agreement. Inter-rater Kendall's coefficient of concordance for round 3 statements was represented by W, and it showed moderate agreement. And there was significance with a p-value of below 0.001, and moderate agreement show we had both concordance and consensus. There was weak agreement of 0.2 amongst the physios in the final 66 round 3 statements, compared to moderate surgeon agreement. And in addition, we did a Wilcoxon sum rank test, which showed stability across all statements, so people were consistent in their views. So here's a summary of the consensus statements agreed upon. There's just not time for me today to go through everything, but the right-hand arrow spanning down all phases of care showed a series of overarching considerations, physio treatment modalities, and the involvement of the MDT. So phase preoperative care. So this was looking at setting goals, expectations, education, and a home exercise plan. And our inpatient rehabilitation included early mobility progression and an activity guide for discharge. Early phase 1 looked at reducing stiffness, surgeon review, addressing psychological issues, wound checks, and restriction of sports and exercise. And this was really well defined. Phases 2 to 4, so phase 2 involved a surgeon or physio appointment. Phase 3 looked at participation in sports and exercise, as well as a surgical review. And phase 4, there were no restrictions from 12 months onwards. So what does this mean? So this Delphi was the first ever consensus in post-op care and generated a series of statements over 9 major themes, as well as inclusion of the MDT and philosophical approaches. A large number of statements were generated supporting rehab in the initial and early phases. We know from our previous work that individuals with AIS desire post-op guidance and want to return to sports and exercise. And we also know from the literature that rehab is an important means by which to facilitate this journey. However, the intermediate and late phases of rehab just lack definition. So what does this mean for us as professionals? Collectively, as an MDT, we all need to be offering patients guidance around managing their expectations regarding return to sports. Surgeons can be supporting rehab, particularly where there's guideline gaps, and regarding safety considerations as well, regarding return to sports. Rehab experts and physios offering a graded approach to rehabilitation that's multifactorial. And all of us, both researchers and clinicians, have a role to play in contributing to the development of guidelines and consensus where these question marks exist. So thank you for listening. The protocol, I'm very privileged to say, is published open access. The manuscript has been submitted, so hopefully that will be available soon. And for the rest of my published works, please just visit my ORCID or drop me an email or speak to me afterwards.
I think if we could have the previous two speakers back up, we'll take questions for those first three papers together, if that's all right. Just a few. If there are any questions for those first three papers. Stunned silence.
Jonathan?
There isn't one. Oh, it's over there.
You don't have to walk. The recommendations for the vibe sequences are that you use a 3T MRI. Did that apply to you, or did you use a 2.5?
No, from what I know, ours are 1.5s, and it's not a vibe sequence, actually. So I apologize.
Oh.
The title might be misleading. I think they wanted to bring a Californian sort of vibe to my talk. It was more that it is an entirely new sequence. It is not vibe. So vibe is about how you can use MRI to sort of look like bone, but actually this is all about how do you get an MRI to be genuine Hounsfield units. So it's an entirely new sequence. That's why it took an extra 4 minutes in the scanner. But as of this year, the time has been reduced to 0 extra minutes.
Okay, well that was good, wasn't it?
Alex, just a question for you. Pat Kiley from Dublin. With regard to the magic rods, our experience is that we see less autofusion in the magic rod cohort compared to traditional growth rods, and that the final definitive outcomes are potentially better in the medium longer term in terms of overall correction and alignment. Did you have any findings like that?
We didn't look at it specifically. I've personally found autofusions across the length of the rod to be a problem if you've got the magic rod housing or a traditional rod housing touching the spine. So my feeling is probably that it's good to go early and if you're going to do a magic rod or any growing rod, is to do it when the curve is like 50 degrees rather than 75 or 80 degrees, because then you're really having to actually do a correction in order to get the rod in. You're touching the spine, and as soon as you touch the child's spine, you know that you're going to start to promote bone formation and autofusion. So I have to say I'm guilty of waiting and doing it when it was only clearly the only obvious thing to do. But Hilali used to do it much earlier than me, and I think probably his results are probably a bit better from that point of view. But he'd operated on many, many more kids, and I would have been able to brace, and then do a final fusion, which is usually my preferred method of trying to treat these in-betweener, early onset kind of curves, so that I don't have to have a growing rod program for hundreds of kids in the region.
I have a question.
Go ahead.
I'm a consultant in India. So my question for the author with magic rods is like, have you faced any metallosis in this patient when we have fused finally?
Yeah, I mean, there's tons of metallosis. I mean, we end up taking out this grey tissue and excising a great big lump of muscle alongside it. So yeah, there's always metallosis.
Right.
Round,
Another thing is like when have you found any discrepancy in the amount of distraction showed in the like ultrasound, this growing, this machine from the actual distraction that happens inside the patient?
Yeah. So the machine that you use, that you put on the magic rod, it just tells you when you press the go button that it could have distracted something. So if you just have no magic rod in the room and you hold the machine up like this and press go, it will go 0.5, 1, 1.5, 2, 3. So it's not telling you how much it's lengthened, it's telling you what the maximum potential lengthening could be. So you've got to check that with ultrasound or X-ray or whatever, just to make sure you've actually got what you want.
Sudarshan from Alder. Question to Alex again. Alex, we found this, it's interesting that you showed the broken, fractured rods, actually. All of them were single rod construct.
Yeah.
I think we experienced the same. I think initially we did a lot of single rod because of how big the curve was, and we could not get the other rod in. And majority of them fractured exactly where it's a junction of the bottom screw and just above where the rod that's...
It's not clear to me whether that's because it's a single rod or because it was one of the early versions that had a weak point at that exact area.
Yeah.
I suspect a combination of both, because we've seen in traditional growing rods that there's a failure rate which is higher in single rod than compared to dual rod construct. But I think that what you're seeing in the complications that I showed is the complications of the early versions of the rod. And actually the rod that you're putting in now, well, we're not allowed to put it in now, but I think we need to address that, whoever's on the board of advisory things, whoever, is less. Yeah. So it's a completely different implant.
And also, Pat, I think we think that it's the same, like the autofusion is slightly less than a traditional growing rod, but also I think where the autofusion happens in the magic rod is where there's on the convex side, not on the concave side, but it's on the convex side where it's rubbing on the TP.
Yeah.
That's where you get a bit of autofusion, but actually the facets are well preserved. And that allows us a bit more further correction, I think, in the definitive fusion.
So perhaps autofusion is not the right term. Perhaps ectopic bone or whatever is a better, because once you've removed that, as you say, there's often some residual movement in the spine. Right. But every case is different. You can get ones that are solidly fused and don't move at all. Some of those cases, Hilali especially doesn't take the rod out. Doesn't explant the rod at the end of growth. He just stops. Yeah. And I know that there's another point of discussion. I know that the current advice is you must take them out. But if you read the advice carefully, it says unless it would cause significant harm to the patient. And I'm like, have you ever seen a conversion of magic rod to final fusion? It's a nightmare operation. So
especially if the actuator pin is broken, then there's a lot of shredding. I think that's different.
That's different. But if the rod looks intact, if it hasn't lengthened for 3 years or whatever, and there's no loosening or metal problem, and the kid's disabled in a wheelchair, where's the advantage?
Re-extend the magic discussion elsewhere. Suzanne, just a question for you, because you've been standing there patiently. With regard to the methodology, you got the highest concordance for the statement of 12 months return to sport. Does that just reflect Delphi methodology, that you will always get the highest concordance for the least aggressive statement?
So our measure of concordance was actually across the entirety of the consensus. So we were able to say that there was moderate agreement, but we had statistically significant results.
So did you get, what I'm really asking is, what was the range of opinion for that return to sport? Because 12 months is really conservative and very uber traditional.
Yeah, and our experts were very much agreed on the fact that a graded return can start from 3 months. But what that actually looks like in practice remains unknown. And where we had our kind of mid-phase between 3 months and 12 months, there was an incredible amount of dissonance amongst our participants. And so, watch this space. We're hoping to do some future work on exploring that dissonance and trying to bring a bit of consensus to where we lack the data.
I think we were going to draw it to an end for those 3 papers, if that's all right.
So, Mike, can we ask you to come up to look at your freehand pedicle screw placement guides?
Thank you. It's me again, Mike McCarthy from Cardiff. So this is our study looking at the 3D hand screw placement against 3D freehand. Disclosures. I, as Darren, was also given a free lunch and a seminar talk at lunchtime. So the problems. We looked at our data. Don't do that. It's not a good thing to do. and we saw there's about a 10% malplaced screw rate on x-rays, but there was no harm from that. And we were doing freehand placement, and we didn't use II at all prior to 2017. Had an operation, had the screws, had the correction, gets a post-operative x-ray. We looked at intraoperative monitoring alerts in a cohort, about 5%, and a third of those were due to screw placement. And then we looked at all claims in our department over a long time period, and there was about one claim a year-ish for malplaced screws in all patients, and it costs a lot of money. We presented this last year at BAS. That's our freehand top left missed screws with no x-ray. Then we moved down to having II, and then we moved down to using 3D printed guides, and we had a small cohort. The solution to these problems is obviously navigation. Most of these are still freehand. And then the robots and the 3D printed guides are obviously guided, they're jigs. So in Cardiff, we were using the Medacta MySkine guides for all of our deformity cases, pediatrics and adult, and we dual operate. And what we've done for this study is we've looked at 48 consecutive pediatric cases. In total, we've now done 60 with Medacta, 1,000 screws, and then we just dialed backwards. Okay, we introduced it in January 2023. We'll just go backwards, every single case backwards. I think it was 2018, had 70 cases, and we compared the two. Dual surgeon technique, we use pre-contoured rods, monoaxial screws in the apex, polys at top and bottom, normally a block of 4 or a block of 6 at top and bottom. And then we use towers, normally on the concave rod, to reduce the spine to the rod and then do some derotation off the monos. The use of the guides has not changed our workflow whatsoever. These are the guides that you get, and this is the booklet that you get with it, and you can go through that. You can log in online, change the trajectories, the screws, whatever you want to do, or you can just flick through it and write back to the company and say, yes, I agree, proceed. You get a model if you want to pay extra, and this was from one of our first cases. Long time ago, put the guide on the small model and put the guide on the spine. We tend to just hold it in place, finger and thumb, and then the other surgeon will drill the screws in. So let's have a look at the results and what we found. So in the freehand group, you've got equal-ish numbers compared to the 3D printed guide group in terms of number of screws we put in. Levels is the same. We did have, because of COVID and other reasons, I think we had a whole cohort of patients, neuromusculars, that we fixed into the pelvis. So that's why there's slightly more cases to the pelvis. Number of screws per patient, well, suddenly you can get screws into all these pedicles you couldn't get into before. So the screws per patient has gone up. Number of levels remains the same. Malplaced screws has dropped. And that's intraoperatively, so we still get the II. Those 70 patients before will have all had II once we put the screws in. Same for the 3D printed guides. So we had a reduction in that, and we had a significant reduction in on the x-rays of the patients. There was only 2 screws which were long in the 3D printed guide group. The others, there was a lot more long screws. But that's, of course, because you've planned it. You've done a CT beforehand. And that's the data on operative time. Now, we didn't measure the time it takes to put the screws in, unfortunately. So this is a time per of total operative time. But there is a difference. It is faster. We know it's faster. It speeded us up a lot. Clearly, the children all have a CT low dose preoperatively, so that it is, you're giving a child a CT preoperatively. We don't CT the patients postoperatively unless we have to for a clinical reason. So there you are. Cob angle pre and post and change was no difference between the cohorts. And we did, you do experience problems with jigs, and about 1 jig per patient, wouldn't fit right, or there was a problem with it. So in conclusion, using these particular 3D printed guides, we did insert more screws. There were longer constructs, but the operative time was significantly less. There's no change in blood loss, length of stay, and we have significantly reduced mal-placed screws. It's only a matter of time, as we all know, till you put one screw in the wrong place and it's catastrophic. So these devices certainly help with that. Any questions?
Marcus, are you asking a question?
Yeah. Hi, Mike. Thanks for an excellent talk. Darren's just given us an amazing talk on synthetic CT.
Yep.
So what you've got is an interim solution, because once we've got synthetic CT, you won't need a tool guide, because your navigation won't need any radiation because you've had an MR scan. And a navigation tool can allow different people to operate in different ways. This is just for scoliosis. What are your thoughts on that? Do you think this is an interim step, and we're now going to move forward with synthetic CT? Or would you use a synthetic CT to create the jig itself?
So, right. So when the technology is there and proven on bone MRI, and we know it's safe, that's great. But the problem is, this is pediatric scoliosis, and these are small, and the margins of error are very small, and it's not entirely there yet. But it will be, we know it will be, and then you've got to prove it. There are a couple of nuances. Previous surgery, certain conditions, you can't do an MRI and you'd still have to have a CT. But yeah, I think we'll get there with the MRI.
Thank you.
Alex, quick question.
Yeah, hi, Mike. You're obviously a double agent, one of Putin's special, working for Medacta and for Mighty Oak, but there you go.
Yeah. Well, I'll explain that.
No, I know.
It's a patent thing.
Yeah. I think I saw on your slide 3% screw mal position rate with jigs. Is that right?
No, it was freehand and it was down to 0.5.
Oh, okay.
Went from 10 to 3 to 0.5.
Oh, 3 was the
freehand.
Interim freehand with II. Okay.
I think, yeah.
Thank you.
Okay, we're going to move on to the next two papers. We're going to take questions for those together at the end. So, Jonathan, for two papers. First one is distal level in scoliosis surgery for non-ambulatory patients with cerebral palsy. Is L5 an option?
Thank you very much. So I'm a consultant to New Waves of now Globus. So the object in neuromuscular scoliosis is to generate a balanced spine with a level pelvis that maximizes the function of our patient and minimizes progression with the development of pain and further disability. The question is, traditionally, we have had a low threshold for going to to the pelvis. Can we now mitigate that by going to L5 with the all pedicle constructs that we now have available to us? Traditionally, the criteria for going to the pelvis was the main curve of 60 degrees, apex at L4, or certainly below L3, with a pelvic obliquity, and it varies between anything greater than 10 to 20 degrees. Does that still apply? So the object of this evaluation was to look at the radiologic outcomes of a homogeneous group of non-ambulated patients with cerebral palsy with posterior instrumented fusion from T2, T3 to L5 in 2 tertiary centres. So all patients had cerebral palsy, GMSC 4 or 5. Over a 10-year period between 2010 and 2020, age 10 to 18, all had a posterior fusion with pedicle screws. They all had measurements of the main curve and the pelvic obliquity and the subsequent changes post-operatively, and whether or not that was maintained with a minimum follow-up of 2 years. So, 167 patients underwent the surgery, of which we had 106 essentially with complete data. The average age was 14, they weighed about 38 kilograms, sex was about equal. The follow-up was a mean of 5.2 years, and the majority were GMSCF5 with an ASA of over half were ASA4. So what were the surgical times? The surgical time was between 3 and 4 hours per case, 15 to 16 levels. The implant density was about 1.4. Estimated blood loss was about 500 mils. The length of mean stay was 18 days, of which there was quite a variation. If you look at the bottom of the slide, one patient at GOS stayed for much longer. T2 in 3/4 of the rods, all to L5. The complication rate was relatively high. That's because I think, you know, when you look for the complications, you find them. The SSI rate was 6.6, which I think is reasonable, but we had no metalwork failures or return to theatre for metalwork failure with an average follow-up of 5 years. So how good were we? Well, the curves are pretty big, 90-odd degrees, and they were reduced down to 42 degrees with a mean change of about 55 degrees for the main curve. The pelvic obliquity went from 25 degrees down to 12 degrees, and this was maintained at a minimum of 2 years of follow-up. So these are just some examples. So in conclusion, we achieved a satisfactory correction with pelvic obliquity that was maintained at 5 years. Therefore, we consider that going to L5 is satisfactory. We still go to the pelvis, but our threshold for doing so is now much higher. Thank you very much.
You want to go straight on to your next talk and we'll do questions?
I'm on a roll. Okay, so spinal presentation in children with spinal muscular atrophy type 1 following gene therapy treatment with, I always mispronounce this, Jane Abopovac. I call it OA. This is from the SMA Reach UK network. So type 1 is a recessive 1 in 10,000 births. It's a mutation of the SMN1 joint with a failure to deliver the SMN protein within the spinal cord, with subsequent degeneration of the spinal motor neurons leading to progressive weakness. SMA type 1 is the majority, 50 to 60% of the SMA type. And up until the arrival of these disease-modifying drugs, the majority, 90+%, died within 24 months of birth. That has been transformed. OA, which is a single gene therapy with intravenous single-dose application, was authorized by the FDA in 2019. And it has dramatically changed the natural history of this condition. This is a paper from The Lancet in 2023. It's looking at the CHOP INTEND score, which is 0 to 64. SMA type 1 are usually below 20. A normal child of the same age is above 60. That score, if you give it before the age of 16, is improved by 17 points. It is radically less the longer after that time you give it. So it does make a material change in their ability to sit, as we will see. So the object is to assess the degree and prevalence of spinal deformity within these children, measuring asymmetry, coronal plane, the sagittal plane kyphosis, or the combination of both in those that have received a single dose of OA. So 12 out of 16 centers presented patients. Between March 2021 and December 2022, 93 patients were given the gene, of which we have data for 75. The sex distribution was the same, and the age at infusion was 11 months. So the results. The median age at which they were measured was 40 months. So they're all still alive. And 70-odd% had a spinal asymmetry. Oh, that's perfect, yeah. 49% had a kyphosis and 28% had both. So the vast majority of them had some form of spinal deformity. But what is also interesting is that 59% were sitters. So they were able to independently sit according to the WHO criteria. Imaging was poor. Only 14 patients had Cobb angles measured, and the average was 25 degrees, and obviously the range was from 0 to 83. Of note was so 71 were braced. This may inform our management as a group of what is being done out there, is that 39% were given a brace prophylactically and 47% were treated with a brace following clinical diagnosis of a deformity. So the limitations are, there's no standardization of the clinical deformity. This was physiotherapy, clinical examination. There's a lack of x-rays with this. And some of them, as you will note from the slides, had other disease-modifying drugs as well, and we haven't standardized for that because the numbers are too low. So the spinal deformity was almost universal. It developed. The majority were braced. So the future is that we need to standardize our evaluation of this so that prospectively we can evaluate what the natural history of these young children is going to be and what interventions we can, as spinal surgeons, require to be done, which I think is almost inevitable. It's published here. Thank you. I probably went a bit over.
Thank you, Jonathan. Well within time on both talks. So any questions for Jonathan on either or both of his papers? So, Jonathan, what would you say to us about bracing? How do you view these children who are a brand new invention of scoliosis in our careers? What's your thoughts?
Well, the actual evidence for bracing is paper thin, and we do it partly because we can't think of anything else to do. It's interesting, in February 2022, the European Neuromuscular Group published in J. Posner about it, and their consensus was 80% agreed that if you had a curve between 15 to 50 degrees, you should brace them, and if it was above 50 degrees, you should do an operation. It's similar in a way to achondroplasia in that there is no evidence at all that bracing makes any difference at all, and yet it is almost a universal practice to begin with. You can only brace these children during the day. At the night, the vast majority are on NIV. So whether or not it makes a difference, I think we don't know, but it makes everybody feel better. And I think that's about as scientific as it is.
Alex?
Well, I was going to ask a different question, but I'll come in on bracing. Is that I use bracing in neuromuscular conditions, not because I'm under any illusion that it prevents the curve getting worse or has any influence on the natural history, but because it can help sitting balance in some kids. And it seems to be functionally they're a bit better.
I completely agree with that. It's whether or not it prevents the deformity from developing and or progressing. It may slow the deformity, I agree. But sure, it sets them up and you may get them to an age later where you can then do an operation.
Yeah.
And I agree with you, definitive.
So I think people use it and that's the reason why. Two questions. One is the new magic treatment for SMA type 1 is also being used presumably for SMA type 2. And making them a whole lot better than they used to be?
The answer is FDA approval is for SMA type 1.
Okay, but there's another treatment for SMA 2.
Yes, nusinersen and risdiplam.
So what you're doing is converting SMA type 2 into non-surgical candidates, and SMA type 1, who always used to die, into
there's a whole bunch of...
so you're not going to be out of work anytime.
No.
Yeah, and the other thing about fixing to the pelvis or not is, did you ever have to revise any of your fixations that you went to stopped at L4 or L5 to the pelvis at a later date?
No, with the 5-year follow-up, no, we didn't, and that was so our complication rate overall for medical complications was the same as that reported in the literature. except for the need for unplanned return to the operating room for metalwork failure, whatever that metalwork failure. So we had no metalwork failure specifically.
Well, that's brilliant. I mean, the paper I always like to quote is David Skagg's paper, because it's got the best title ever, called "Don't You Just Wish You'd Gone to the Pelvis the First Time."
Yeah.
And they did have some cases where they had to revise and extend it to the pelvis because of further deformity. Not, I don't think, because of metalwork failure, but the revision surgery is tough.
I completely agree, but as yet, we haven't looked specifically at that question, but anecdotally, because I've been there quite a long time now, there has been some pelvic tilt, but has it necessitated an operation? The answer is as yet, no.
I mean, you can obviously pick them, so well.
Pat?
Just thanks for 2 great papers. On the SMA group, it's interesting. I had one at the clinic just 2 days ago, SMA type 1. Very worrying early kyphosis. It seems to be the pattern. I'm sure you're seeing far more kyphosis issue than scoliosis issue. And brace treatment started. They have the network in the UK, so they jump on the boat or plane and they go over. And they all get braces in the UK, and actually quite a staggering result, at least a 50% improvement. And that was in a picture sitting out of brace for X-ray. So it certainly seems to be holding quite a lot of them. Again, I was very skeptical, but it does seem to help with kyphotics.
The efficacy of bracing is, as we discussed, do they sit better with it? The answer is yes, but will it help the natural history? I don't think. That's where there is no evidence.
No, but the correction that was maintained with brace, maintained when you have them seated X-rays with brace off, which is very interesting.
Yes.
And so their alignment seems to be, whether it's guiding the growth to some degree or not, but these are very small numbers, so it's hard.
Well, we don't know. That's why my point about the future is we need to measure these children.
Thank you very much, Jonathan. We'll call that session to a close. So, Pat, don't sit down. Thank you very much indeed, everybody. So, apologies. As you know, we've been running late since lunch, so we will be eating to coffee time a little bit, but it's my great pleasure to invite Mr. Kiley, my friend and colleague who works in Ireland. I've known him since he was a trainee representative at the same time as I was, and then we had the pleasure, I think, there's a word of working alongside each other as successive fellows in Nottingham. So he supported me with an occasional beer when I was stuck in Nottingham on call. So it's great to see you speaking here, Pat, so thank you.
It brings me back to a few evenings in the rope walk when you were on call. Yeah, we want some more about that. So my remit was to talk a little bit about post-surgical kyphosis. And if you look at my name, you can see my initials spell doom for my personal self. And I've always wondered why this pursued me around so much, but there you go. Maybe that's why I got invited to give the talk. So that's the new kids' hospital, where we will have no problems and all these issues will disappear, of course. I'm going to move in there in a year's time. Post-surgical kyphosis relates really, I suppose, to a sagittal plane deformity, and this can be seen at the proximal or distal end. It can range from radiographic findings to a full mechanical or biological failure requiring revision surgery. And by definition, there's a little bit of variability in the literature, but at least a 5-degree, and most people accept a 10-degree change in the area or zone, anatomical zone, would represent sagittal plane kyphosis. We're just going to talk a little bit about the definitions, about some of the symptoms, the prevalence, the risk factors, and maybe some preventative thoughts, and some treatment options in cases. So proximal junctional kyphosis, my initials again, is a kyphotic deformity in the spinal motion segments immediately cephalad to the upper instrumented vertebra, and a greater than 10-degree change or the prevalence of kyphosis of 10 degrees in that segment would be diagnostic. It's not always symptomatic, of course. This is differentiated from proximal junctional failure, which is where this is an element worse. If you like, the kyphosis finding may be a postural definition that you can anatomically or biologically control or contain. But proximal junctional failure is a manifestation of both deformity and instability, where the muscle, soft tissue elements, ligamentous elements, bony elements, disc may all be failing, or the metalwork may be pulling out to lead to define what is really a true instability of the area. And of course, the vertebra can also fracture, particularly we see that in the elderly population with osteoporotic tendencies. It is much more likely to be symptomatic and sometimes can present, as in this picture, with a neurological deficit. I'll talk about her a little bit later. Key differences, therefore, are that PJK, in its truest sense, is purely a radiological finding. And this is another patient that's not always proximal in the proximal spine. It can also be in the lumbar area. This is a Parkinson's patient that we inherited who previously had a few surgical adventures. And you can see she actually presented in a wheelchair because she was unable to stand. And she's got a severe picture understanding, actually demonstrating a proximal junctional failure, in effect, in the lumbar spine with instrumentation to L4. Her situation, of course, is progressive. In contrast to junctional kyphosis in the upper end, you can also get junctional kyphosis in the lower end, and the definition of this is somewhat similar. It certainly seems to me that sometimes a vogue for segmental thoracic correction led to an increase of this entity, and this is a patient of mine, I'm not proud to say, who had a segmental correction and started to have protruding metalwork and discomfort in the thoracolumbar area. It's often seen with longer spinal fusions terminating, particularly at inflection points. So if you're terminating in the cervicothoracic junction or the thoracolumbar junction or the lumbosacral junction, that's where you're really going to be vulnerable to this kind of issue. But I do think we should also need to recognize that it's not always so barn door obvious. It can happen even after a small operation. It can be devastating. So this is a very functional gentleman who had a discectomy, and somebody, just for good measure, threw in a nice intraspinous device for a disc prolapse at the L4-5 level, and you can see he's collapsed right down. I don't think due attention was spent looking at his sagittal balance and his pelvic to lumbar lordosis requirements. If you look carefully at the x-rays, you do see that he's actually relatively kyphotic at the L4-5 after his discectomy, and you can see he's floridly symptomatic both on the SPECT scan and MRI, or at least floridly abnormal, and you can understand his florid symptoms just from that relative kyphosis in this area. So it's something to be borne in mind, and I suppose for our neurosurgical colleagues, you know, it doesn't always become so evident on a MRI. It's really important to have standing weight-bearing x-rays to look for these sagittal plane deformities, which can be really prevalent. Distal junctional failure, again, is a step worse, where basically we have a severe structural complication requiring revision. And in this case, you can see that the screw is pulling out. You may have vertebral fracture, you may have metalwork migration, and a complete loss of balance. This patient didn't have a neurological deficit, but did have radicular leg pain associated with the screw movement. So key differences, again, one is a radiographic, maybe more benign finding, the other requires evaluation and instrumentation. And you can see in the patient I showed you earlier, we did have to extend the zone of instrumentation and correction. Thankfully, it was flexible enough to get reasonable correction and alignment without proceeding to the lowest part of the lumbar spine. So hopefully he'll have reasonable function in the future. In terms of clinical presentation and symptoms, this is an interesting girl who wasn't long back from Nottingham into Ireland. She was initially diagnosed with AIS, but she was borderline ataxic, as we saw her repeatedly at the clinic during her waiting time. And we got an MRI scan of spine, which demonstrated in the brainstem some abnormalities. So she was diagnosed as having a fatal condition called Alexander disease, which is a demyelination problem. As the scoliosis got worse, we eventually, she had her surgery despite having a fatal prognosis, and she did really well until she returned under another colleague's call 2 months later with increasing ataxia, enuresis, and just going off form generally. Everyone thought it was her brain getting worse and put it down to that. She wasn't probably looked at carefully enough clinically. And I went to look and see what was going on. I went in to see what the radiology results were, and I came across the SCOUT film. You can see the right-hand film for her brain scan. And I went, oh shit. She developed this proximal junctional failure, and we had completely missed it. on look back, we can see the radiographs didn't really measure or look out for this properly. And you can see her actually how dynamically unstable the situation is when you do a proper X-ray. Just that was done the day after. So overall, the prevalence is actually quite large. If you look at it in the adult population, 20 to 40% of adult spinal fusion patients get adjacent or get punctural junctional kyphosis. And this relates to their failing biology and the prevalence of degeneration. Distal junctional kyphosis occurrence is much lower at about 15 to 50%. That's probably a good thing, but certainly long fusions down into the lumbar spine with underlying degenerate changes adjacent are a problem. It's very important to think about it because it's very important for if it's a high likelihood for our preoperative counselling and consenting, and also for our plan and post-operative management. There's a huge vogue in Ireland and for our managers to try and get us to discharge all the return patients because they don't want them filling the clinics. So we're being all the time pressurized not to bring people back after 1 to 2 years. But there's a great talk, and I've attended a North American surgeon says basically when you become a spine surgeon, particularly a deformity surgeon, these are your patients for life. And you say to your patients, I'm not your spine deformity surgeon for life, but I'm going to be your spine doctor because you will need to be watched. And the prevalence of these issues really reinforces the need to be vigilant and to have systems which allow us to monitor our patients in the longer term. So the other thing about these junctional problems is it increases with time. So as time goes on, we could say these patients, well, I used to do surgery to these patients back in the 80s, but gravity always wins. So gravity and time will always win, and we'll see an increasing prevalence of these issues as time goes on. So we really need to follow them at that point again. So what are the common risk factors for this? Age-related, so under 55, over 55, high BMI, bone quality, underlying neurological or syndromic disturbances. These are recurrent issues, underlying connective tissue issues. These are recurring etiologies for this kind of problem. So we can see that fragile and failing patient, I showed you her X-ray earlier, she's 75, she's had CSF leaks, 2 decompressions and all that kind of trouble. She's got a number of risk factors in terms of her bone health and her general biological health and neurological situation to make us wonder, should we be able to spot this before it happens? So that's where she was after the initial fusion, and you can see on the right-hand side how she's really gone off over time because of age, time, and her neurobiology. We can look at a number of different risk assessment tools then to try and highlight from our perspective which patients do we need to watch for, and certainly the PJK risk score is very useful. There's a number of other scores as well to look at radiological parameters, such as the GAP score and so on. But we certainly have not got all the answers and all the tools to really define the risks fully accurately. But there are tools which are out there which need to be thought about. If we look at the literature, the position of the weight of the patient, the age of the patient, you can see that the risks go up immeasurably, which the location of the upper instrumented or lower instrumental vertebrae, again, their proximity to the inflection points of the spine. These are major weightings as to whether you're going to see this problem, yes or no. So overall, the importance of risk scoring is then helps us really in terms of making predictive algorithms for our patients, predicting their outcomes, whether they're going to have a good result or not. And I think every surgeon would wish to know if they're likely to have a good outcome or not. So it's really important for us to start thinking wider in terms of can we predict the outcomes greater for these groups. It also allows us to tailor the interventions for the patients within these cohorts to maybe biologically or pharmacologically get them to improve to lower the risk and improve their personal outcome. And it has impact in our overall decision-making framework within the hospital and within our team and in a wider national level. There are clinical implications for findings using scoring and risk systems. And we need to take the time, I suppose, and take the steps and get the data to try and ameliorate or mitigate the risks that are definitely there. And that is not easy in a busy clinic of 40 or 50 patients or whatever number you deal with on a normal day, and especially if it's a non-specialized clinic. These situations do need to be managed more optimally. Perhaps the requirement to take on board these data collection elements would allow us to reduce down the size of our clinics and stop and think and take the time to prevent some of these problems. But it doesn't mean operational changes potentially in dealing with this fragile and vulnerable patient group. There are, with each tool that's out there in terms of risk assessment and risk mitigation, there are useful elements and there are weak elements. I suppose what's useful is that some of the scores are pretty simple and you can almost definitely identify a high-risk patient. But with a lot of the scores that are out there and the systems that are out there are not really wide enough and broad enough in their scope to really capture all of the factors that can contribute to increased risk. And I suppose one of the things, of course, is that a lot of the parameters we look at in terms of radiology are from static positions, and they're not looking so much at the dynamic capabilities of the patient or their true biological strength. But it certainly should allow us to potentially become more accurate in our predictions and in our prevention of complications. So when it comes to the treatment options for these patients, I suppose we've got a number of options. If they've just got a junctional kyphosis without instability or failure, you can observe them or consider non-operative treatment. You may need to extend the instrumentation, as we talked about before. You may need to add in correction, and you sometimes may need to consider anterior and posterior techniques, interbody techniques or osteotomies. I deliberately put the textbook in there because I'm not going to talk a lot about the osteotomies or the sexy operations. A lot of the time we want to be dealing with these fragile patients in a more gentle way. So, a case or two. This is a patient with early onset scoliosis. She's both structural in that she's had a number of cardiac procedures and I think a diaphragmatic hernia repair as well. So her tissues are not flexible, she's scarred and probably stiff. And she's also got an underlying syndrome. You can see she's got a nasty enough curve. I think nearly all our TGR, our growing rod patients were close to 70 degrees at time of surgery because we'll try to defer with bracing and casting until we have to pull the trigger on it. She had a growing rod inserted in August of 2020, and you can see she had her first growing rod failure there on the right-hand side. That happened about a year later. She had another growing rod failure and to try and get control of both her spine, which is getting progressively kyphotic, and her breaking rods being reinforced, the situation with paraspinal rods. So she's got to that point, and she's now 9.5 years of age. She's 5 years down the road. She has kyphosis, but I don't need to intervene, so she'd fall in the observational category, but it would be close observation from my perspective. A situation, as my boss used to say in Dublin, don't ever operate on a Marfan's patient or a Ehlers-Danlos patient or a spina bifida patient or in so many different categories. I think no surgery happened, but occasionally you're forced to do so. So this is an Ehlers-Danlos patient with mitral valve disease who's a little bit unstable from a cardiac perspective. He's also unstable from a biological perspective. He had his correction, and then you can see 18 months post-op, he starts to complain of pain and protrusion of the implants at the lower lumbar area. You may argue maybe we should have gone a little lower early, but he's already starting to flex and fail there. The CT scan demonstrates that he has a lysis around the screw and he's pulling out, so he's a distal junctional failure. And what was really interesting at his revision or extension and correction was really how little bone graft formation or bone fusion mass formation there was, how some of the graft was still static in the wound there nearly 2 years later. Like there was no biological incorporation or actual biological bone formation activity going on. And so that also highlights the point that some of this is actually a non-union or failure of bone formation phenomenon as much as a malalignment. I suppose secondarily it also is, it's a connective tissue strength problem as well, and maybe muscle tissue strength problem. So there's a lot of dynamic factors involved in this, and I'm actually considering whether we need to do interbody fusion in him in the lower area just to try and get a solid fusion, because the chances of getting solid fusion just from the back alone, given our findings at the time, are pretty low. We can consider further levels of treatment option or further extensive treatment, so extension of fusion and correction. Well, this was an interesting conundrum for this lady, and at the stage I got her, I was quite a fan of the MAST technologies, the minimal access spine techniques. Now, she'd previously been tied up in Beaumont Hospital with recurrent CSF leaks, probably for about 3 months on 2 occasions after her decompressions and fusions, and the neurosurgeons there didn't want to see her again.
So going back into that soup, and you can see the MRI scan shows a bit of a pool there, was not something that was too attractive. So I thought maybe we could try and get away without kind of opening up the can of worms. So we tried to stay above the zone of trouble, and we went for interbody cages to get a correction of her lordosis and to stabilize her. It was a much lower impact, potentially, I thought. She did start to flex. We were watching her like a hawk after that first stage procedure. And as soon as she started to pull off at the top end and start to develop proximal junctional kyphosis, we went with augmented screws and kyphoplasty. And more than 4 years later, she is still holding okay, but I kept her in a brace all the time. She came into the hospital or to the clinic in a wheelchair, and thankfully she's still mobile with the aid of a walking frame. So she's done okay for someone who is biologically very challenging and also surgically quite challenging. So what would be the future directions of travel for us? I suppose we'd like to develop or improve and enhance our risk assessment tools, and I think really getting better indices of the patients' in indigenous ability to improve their strength, their power, their sarcopenia, I think that's important. Similarly, their bone density. I think their cardiovascular risk, it's really interesting. One of the most fragile patients I ever had was a patient with a single ventricle circulation who wasn't really deemed to be fit for a haircut or even an operation. She went into a conditioning program, this is a kid, for about 6 months prior to surgery, and she changed her ASA grade really from 4 back to about 2.5 and sailed through surgery. So I often think we don't look to the physical or physiological capabilities of our patients enough in terms of improving their risk profile. Of course, we need to be enrolling all these patients into our databases, but one of the biggest regrets is we don't have enough data from when I went back to Ireland and started to deal with a myriad of all these problems. And I think we need to lean more on a multidisciplinary insights and abilities. But I think we need to think very much in all dimensions on this. So it's not just the sagittal plane problem, it's often coronal plane and rotational. It's also trying to get the front of the spine to fuse as well as the back. And I think we need to think about if it's thoracic, is this thoracogenic, or are there other potential issues that can be leading to the problem or the solution? So, a couple of cases if we have time. Do we have time? So this is a 15-year-old with progressive Sherman's kyphosis. From Donegal, also the X-rays are not so great in terms of their quality. But he had a kyphosis approaching 80 degrees, and he had his surgery done. And the initial post-operative situation looked okay. He was about 16 at the time. He had a surgery. He was 15 when he turned up at the clinic for the first time. Unfortunately, you could see there about 1 year post-op, he starts to pull off the hooks. So I normally use hooks at the top for a soft transition point to try and reduce the stiffness of the construct. And maybe I wasn't high enough, but I think we were at T2. But he did start to go. One of the other things I think with Sherman's kyphosis in particular is our instrumentation system is so powerful in terms of correction. It's fairly easy to overcorrect, given the power of pedicle screws and rods and configurations we have now. So I'm super cautious now not to overcorrect. So he went off 1 year post-op. We extended his instrumentation, wanting to have a soft landing. We went with this lighter rod, into the cervicothoracic region. And everyone happy? Not so much. So he held for a while, and then he developed further kyphosis. And 2.5 years later, I came to hear that he was a recluse, that he was basically living in his room, that he basically kept the curtains closed all the time. He was severe depressive illness, and he didn't want to go out because he was so embarrassed in his appearance, and really even getting him to come back for follow-up appointments to check how he was doing was almost impossible. So we were relying on our colleagues in the northwest of Ireland to try and get him into their department for imaging from time to time. So this situation, we're now a couple of years down the line after our failed attempts. What would we do? We got him back eventually and put him on halo traction for a while. You can see that the metalwork is starting to disconnect, that also indicating some pseudoarthrosis in the area. So what do we do next? Do we go up into his neck? Do we do a high thoracic osteotomy? And this is where my British brethren and the Philip Zarb group gave me a little inspiration. So I met this man, Richard Gross, through the Zarb movement, and he had some really interesting thoughts. And I think, Lee, actually, when we were in Nottingham, we also had similar thoughts because we have a few very, very recalcitrant kyphosis cases that just kept on going off. You see, the thorax, or say that the spine, is connected to the thorax, and the rib cage and sternum are very much the fourth dimension of your spine. A very interesting paper that was initially, I think, done in Germany, where they showed that if you release the ribs or you release the sternum, you get far more mobility of the spine than you'll ever get from a vertebral column resection or any form of osteotomy. So the shape and, I suppose, anatomy of the thorax is crucial in this area. And Richard took that a step forward further, and he basically started to look at overall biomechanics in the thorax. The head is a really heavy bowling ball on top of a flexible column. And so your shoulders and your shoulder girdle, if it starts to roll forward on your thorax, also has a significant mechanical disadvantage for you. So looking at that and looking at pedicle screw pullout from the upper spine, he started to examine rib claws and rib hooks, slightly different from the vector system as a way of controlling the moment for flexion and kyphosis. He got me thinking anyway. So we, rather than going into the neck with this individual at the failing top end, we thought we'd go to the thorax. So we did a instrumentation in a claw configuration, as you can see, with paraspinal outriggers. To me, when you look at the metalwork, it looks like a light bulb. So we call this the light bulb operation because it looks like a light bulb filament. And I think this is a very useful little discovery for us. It certainly held his upper thorax in a good position. It's acted like a cantilever holding onto the rib cage and actually shifting the point of loading, biomechanical loading, away from the kyphosis he had. And he's maintained that now for at least 4 years. So it's really been transformative and has made me think a bit more about this. So, conclusion, junctional deformity, or post-operative post-surgical kyphosis. What can we think about it? Well, it wears us out, that's for sure. It wears us out. Will you leave it at that? Thank you.
Thank you.
Many thanks, Pat. Any burning questions? We are over time, but happy for one question if everybody's solved the problem.
We've got one at the back there.
Oh, Sachin, you gonna?
Okay, I think.
So, Pat, it's a pleasure to shake your hand and thank you for giving 2 talks to the meeting. But, thank you very much.